You're all very welcome this afternoon to our Sláintecare webinar. I'm Gráinne Healy and I'm delighted you have joined us today. The Sláintecare webinar today is our 22nd in the series, and we're delighted to be delivering it in partnership with the HSE. As always, we are happy to take your questions or comments from you, the viewers. Just use the chat function and I will bring your questions or remarks to the panel of guests we have with us here this afternoon. Sláintecare is about the right care in the right place, at the right time, by the right team. We're focusing today on an integrated care pilot of an occupational therapy vocational rehabilitation service called Workable Solutions. People with musculoskeletal disorders, or MSDs, and arthritis often experience challenges at work due to their conditions. Many have associated temporary work absence. Indeed, low rates of return to work, to paid work and permanent work disability is common amongst some sufferers. Workable Solutions is supporting people with MSDs to remain in work, and it's funded by the Sláintecare Integration Innovation Funds. Today, we're going to hear all about this project, its origins, the pilot sites, its operation, the team behind it, and the benefits it brings to those suffering with MSDs. I'm delighted to have the current HSE clinical programme lead for rheumatology with us today. He joined me earlier to speak about his work and the pilot programme and to introduce us to the subject of rheumatology. I'm delighted to welcome Professor Kane to the webinar to speak to us about Workable Solutions. You're very welcome, David. Thank you for joining us.
Thank you very much, Gráinne.
Would you tell me, first of all, what is rheumatology and what are rheumatic and musculoskeletal diseases?
Rheumatology is the medical specialty that deals in advanced therapies in rheumatic and musculoskeletal diseases. So, for instance, rheumatic and musculoskeletal diseases are what people commonly refer to as arthritis or rheumatism. And these are conditions where you get joint pains as the kind of main manifestation, the main reason that you attend a doctor. About 1.2 million people in Ireland at the last time we surveyed would self-identify as having arthritis or rheumatism. Now, clearly, not all of those 1.2 million need to see specialists, and most rheumatic and musculoskeletal diseases can be managed at a primary care level by your GP, by a physiotherapist. But some will need to see a specialist. Whereas many patients recognize what orthopedic surgeons do in terms of surgery, rheumatology is a funny one in that most people don't really get what we do. Most people with rheumatic and musculoskeletal diseases don't need surgery. They need medical therapy. And for diseases like rheumatoid arthritis, we have drugs that manipulate the immune system, which causes that arthritis, and correct it and give them back good health and reduce the pain in their joints. And so our specialty works by using medical therapies to fix your joint pains and your rheumatic and musculoskeletal diseases.
Fascinating. Thank you for that. The National Clinical Programme is central to the development of the HSE modernised care pathways for rheumatology. What areas have you focused on initially?
Well, probably the most severe of the rheumatic and musculoskeletal diseases is inflammatory arthritis. And the typical disease in that group would be rheumatoid arthritis. I think if you've ever known somebody who had rheumatoid arthritis in the pre-biologic therapy age, you would have seen that they had deformities, that they ended up requiring joint surgery for their damaged joints, and they suffered really poor health. On top of that, most people with rheumatoid arthritis, if they weren't treated, would end up out of work after 5 to 10 years. So these diseases have a huge impact on your joints. However, they're not caused by wear and tear or getting old. They're caused by your immune system. And so rheumatology has carried out a lot of research and trials in these diseases, found that there are specific pathways in the immune system that can be blocked with drugs and switch off the disease and give people back their joints again, remove the pain and give them back their mobility and their health and keep them in the workforce and keep them active. So that's one of the key diseases we've focused on. So the clinical program was designed to try and develop better ways of delivering healthcare to patients in Ireland. And our priorities have been on working on obviously reducing waiting lists, but reducing waiting lists first and foremost for people with inflammatory arthritis, because those are the patients who have the worst disease, whom we have very good but expensive and specialist therapies for, and who need to see a rheumatologist. So we're working on a rapid access early inflammatory arthritis pathway to get patients diagnosed quicker with rheumatoid arthritis and other inflammatory arthritis, to get them into the system and to get them on treatment. And the long-term benefits of that are that if we get them in quicker and treat them more effectively at the beginning of their disease, that they end up using less healthcare resources for the rest of their life. We actually keep them healthy rather than medicalize them too late in the stage of their disease. And the other area that we're working on is back pain. Now, anybody out there will probably have had back pain or know someone who's had bad back pain. We all, 1 in 3 of us will get a bad episode of back pain in their lives. But there's specific diseases, again, caused by your immune system called the spondyloarthropathies that cause inflammatory back pain at a young age. And again, they have huge impact on your mortality, morbidity, ability to function. And yet the drugs we now have can actually reverse that type of back pain and give you back good health. And so we're looking at working with orthopedics and our primary care colleagues to develop a back pain pathway where we can spot which of the patients have inflammatory back pain and again, get them fast tracked into our service and get them on treatment. So there are our 2 main pathways we're working on at the moment.
And it sounds to me that in all of these conditions, and again, I mean, I can think in my own family, my mother had, hands that were, her knuckles were all swollen and she had things in her legs. And this was the time maybe before these drugs were available. But I'm thinking of the younger age cohort that you're talking about, of people who are maybe forced out of the workforce because literally they have this pain and it makes it impossible, or they have a lot of sick days. So these would be early intervention for those people would be really important.
Absolutely. And that's what we're here to talk about today in our webinar, Workable Solutions. So with Workable Solutions, we're aware that not just rheumatoid arthritis and inflammatory back pain will experience difficulties in the workforce. And we also know that musculoskeletal disease, or rheumatic and musculoskeletal disease, is one of the commonest causes of people actually being out of work. People with back pain can't work, people with joint pain can't work. And the important thing is that once somebody is out of work with a joint problem, the chance of them getting back into the workforce rapidly fall away. So it's really critical that for those patients whom perhaps we don't have immunological therapies for, who just need more coordination of their medical therapy, but also perhaps help in understanding what work they can do safely and help with adaptations to allow them to work, that those patients are targeted and gotten to before they come out of work. So what we call about work instability, patients at risk of losing work, get fast-tracked towards a therapist, such as in this case, an occupational therapist, and that they can help manage that patient's joint condition and also help them adapt in and remain in the workforce. So that's really critical.
Yeah, and I can see the importance of that, getting a clear pathway for care, and then some of the outcomes being, being able to stay in the workforce, and maybe taking people who've ended up on illness benefit, being able to reintegrate them into the workforce, which obviously is hugely important. I know that the service, and it is the first of its kind in Ireland, I know it's available in Dublin, Kildare and Waterford for people with the musculoskeletal disorders and arthritis. In your view, is there potential to scale up this project, to mainstream it, to make it available in wider geographical areas?
Absolutely. I mean, there are going to be people with rheumatic and musculoskeletal disease all over the country and people who are at risk of being out of work. And it's a most frustrating time. Your livelihood is under stress. It has financial implications, personal and relationship implications. It really is quite profound. And at that time, what we most need is a pathway to help people find their way through to help. And that's what this is all about. We're piloting it at 3 sites, but we hope that with the success of the pilot, that we'll be able to expand it to more sites because these patients are everywhere in Ireland.
Great. Professor Kane, thank you so much for doing our introduction to this. We will be speaking about the detail of it with your colleagues. But for the moment, thank you so much for speaking with us today, and the very best of luck with this really important, innovative work. Thank you for joining us.
My pleasure, and thank you to Sláintecare and all of you for supporting this work, which we really think is important and are delighted to be moving ahead with.
Great, thank you. So thank you to Professor Kane for that really interesting introduction to this whole area. To hear more about the business case for this pilot and to explore some of the emerging national results, I'm delighted to be joined now by Yvonne Codd. Yvonne is an occupational therapy clinical lead in the National Clinical Programme for Rheumatology and project lead at Workable Solutions Service. She's also assistant professor at Trinity College, Dublin. Yvonne's going to speak to us about the Workable Solutions service, the pathways, the referrals, the evaluation as it has been carried out to date, and share some of the metrics arising from the programme. Yvonne, you are most welcome.
Thank you very much indeed. I'm just going to share my screen. Okay. So thank you so much for the opportunity today. It's really great for us to have a chance to let people know about this project that we're working on at the moment. And I suppose just to acknowledge really that this project was first initiated by a team of 3, Trish Fitzgerald, Oriel Glennon and myself came together back in 2018, and we were looking at a problem. And the problem is something that Professor Kane has alluded to already, but we were looking at the fact that musculoskeletal disorders and arthritis are among the most common reasons people in Ireland attend their GP, and that they're associated with very high rates of temporary work loss, with 7 million days lost annually in Ireland. And they're also very expensive. The cost to the exchequer by way of illness payments when people are temporarily out of the workforce is estimated to be €750 million each year. As Professor Kane said, there's also a common high instance of permanent job loss, so people permanently coming out of the workforce because of their condition and the impact that their condition is having on their workability. And unfortunately, we know that once a person moves on to a long-term disability payment, only 2% of those people leave that payment for reasons other than death and retirement. So really keeping people in work is absolutely key. In terms of the landscape nationally, what we were looking at back in 2018 was the fact that there are some fantastic pockets of practice around the country where OTs are providing really high quality work-focused interventions. But HSE occupational therapy services, both in the acute hospital and primary care, have long waiting lists, and there is variation in the types of work interventions that are offered down to hospital service level agreements and therapist skills. So we were really acutely aware of a missed opportunity that was there, and an opportunity for us to do something different. And we were looking at the national practice in the context of the research that's happening internationally, and the fact that there were some really positive outcomes coming out of research internationally for people who had inflammatory arthritis, who had access to tailored one-to-one interventions to help them to stay in work. So as a team, we were advocating for change, and we were really agitating for change as well. And through collaboration with the National Clinical Programme for Rheumatology, we were able to refine the problem and come up with a solution that would really apply to the Irish context. And we got a lot of help in terms of developing a business case that was going to really deal with this problem in a good way. And we were delighted when we were awarded the CIF funding for our pilot project, Workable Solutions. It's an occupational therapy project for people with musculoskeletal disorders and arthritis. And to avail of this service, people need to either be currently in paid work and experiencing difficulty at their work on a daily basis, or in receipt of illness benefit for up to 6 months duration. And that's really just trying to put parameters on the project, because a different welfare cycle kicks in after that time. A really important part of this inclusion criteria for our service is that the clients themselves have work-related concerns. So the client themselves wants to stay in work and is seeking support to either retain their work role or seeking support to return to their employment. What's really unique about this service is that we accept referrals from both primary care and hospital, and that really has opened up the opportunity for us to get that early access piece. So in the primary care situation, we are welcoming and very happily receiving referrals from GPs, primary care physios, primary care OTs, MSK triage physios working in primary care. And then we're also accepting referrals from any member of the rheumatology multidisciplinary team in the hospital. And again, just opening up that opportunity for quick, timely access to address the problem. What this OT service is doing is it's offering an initial assessment where there is a detailed assessment of the person, their occupation and their environment, and maybe the barriers that are occurring because of their condition on a day-to-day basis in work. And we're setting goals then to deal with these issues, to provide timely intervention to support workability, work capacity, and work confidence. And I suppose what we've been really lucky in terms of scoping the project is that we've been able to offer a variety of platforms, so face-to-face or virtual, and also we've been able to offer worksite visits if that's appropriate for the person as well. And all of that means that stepped care approach means that we can offer what's needed. We scoped for 4 intervention sessions after the assessment, but really, and as you see with our initial findings, we have flexibility to deliver what's meaningful and relevant for the person. So just to give you a very quick sense of the timely nature of the services, what's so important. So our mechanisms in place make sure that referrals are screened really quickly, that assessment is commenced really quickly, and that the treatment is measured out in a way that's tailored to the individual circumstance so that the interventions are beneficial to them to affect change and to support their work confidence and workability. And then because this is a pilot, we're very much including evaluation as part of this to make sure that we're influencing change both on an individual level and on a cohort level as well. I just wanted to include these so they would be in the show notes afterwards, but there are the 3 catchment areas working out of St. Vincent's. Susan Somerville is there and her contact details if anybody has a referral that they feel would benefit from the service. We're going to hear from my colleague Jane Branley, who operates her service from Naas General Hospital, and her contact details are shared there too. And then we have our 3rd pilot site in Waterford. Katie Mahon is delivering the service there, based in primary care with inward links into the Rheumatology Hospital. And again, her details are available if anybody feels that they would benefit from this referral. Because it's a pilot, we're very much evaluating it. We're evaluating the pathway. We're evaluating the personal impact of this service in terms of the outcomes for the person on a day-to-day basis in their work environment. And we're also evaluating the societal impact, so the savings by way of reducing illness benefit, reducing days lost from work, and presenteeism too. So we're really trying to get a good handle on what the impact of this proof of concept study really is. In practice, the pilot has 3 real elements that we are working on. The first being to raise awareness, and we've had fantastic engagement and support from Arthritis Ireland to help us get the word out there about the service so that people who may benefit know how to access and can access in a timely way. There's been massive engagement with our primary care colleagues by the clinicians on the ground, increasing awareness at the network level, at the GP level, so that people know that the service is there, know how to access it. And the same from the hospital point of view too, that people are aware of what's available and what the pathway for this is. We're also delivering the intervention, so really getting that intervention to each person in an early and timely way. And then we're capturing the data that I was sharing the points with you so that we can monitor the impact and really see what is working well about this. And just to give you a flavour, I suppose, of the metrics so far. So the pilot is operational now for 10 months, but there were staggered starts across the 3 pilot sites. So to date, we've had 248 referrals into this service, and 40% of those have come from our primary care colleagues. So we're really, I suppose, delighted with that number, and it's really reflecting that level of engagement at primary care level as well. 57 of those referrals haven't been eligible for the service, and I include this because this ineligibility isn't due to a lack of need. The primary reason that people haven't been eligible for the service is due to one of our inclusion criteria, because it's a pilot study, that they were longer than 6 months out of work. And that's a really interesting early finding for us, because the appetite for people who've been out of work longer, actively looking for support to return to work, is there. And that's something that we're taking on board while concurrently delivering a service to the numbers who do meet our inclusion criteria too. We've had 191 people who have met our inclusion criteria and who have engaged in their first appointment and are working their way through our programme. And to give you a sense of those, there's a split between those who are work absent. So 21% of them are already absent from work because of their condition and its impact on their workability. And then just under 80% are in work, but struggling in work and concerned about their workability and actively seeking support. 57 of these people are sole income earners. And again, that kind of consequential impact on family and society is huge. And we've had big variation across the types of jobs across the public and private sector as well. So we're really trying to spread the net wide to address that need to anybody who needs it. Just to give you the highlights of how our cohort have looked, the majority are female. The median age, I think, is really important. 43 years is the median age for us clients attending our service. And if you think of that in the context of this is a group of people who have more than 20 years to continue to work, this timely intervention is massively important. We're seeing and treating a wide range of diagnoses, so established inflammatory conditions, also non-inflammatory, low back pain, musculoskeletal disorders, and the complexity of that variation is something that's been dealt with very well by the clinicians on the ground. A brief flavour, I suppose, of the milestones so far. We've had 191 people come through for first attendances, and already 77 have hit the milestone of discharge, and 29 have gotten to the milestone of 3-month follow-up. And of the 77 who've already completed the programme, 73 of them are in work now at discharge. So 95% work retention is a huge number we're really pleased about. At the 3-month time point, 26 of them are now still in work. And again, something that's really demonstrating the impact of this timely intervention. I'm always conscious that the Fit for Work figure that we refer to is a 2013 figure, but it's the only one that we have at the moment. But they report that a cost by way of illness benefits of €9,776 per person is the cost annually when somebody is out of work. So if we look at the figures of people who've hit the milestones on our service to date, the potential for annual costs and recurring costs of people who are in their early 40s is really just huge. A flavour of our interventions, we've delivered 274 intervention sessions to date, and the range has been from 1 to 8 sessions, so reflecting the fact that the service is flexible, meeting the needs of the clients who attend it, but the median is within, as we had expected the project to be, of about 4 intervention sessions. There's appetite for variety in the service users here by way of face-to-face and virtual appointments. And there's also been some but modest uptake on the worksite visits that have been offered where deemed appropriate. On a client-specific point of view, we're measuring metrics across a wide range of factors. So work role functioning, quality of life, self-management, self-efficacy, future work expectations. And while we haven't done the statistical analysis on this to date, we're monitoring them closely. And you'll see in Jane's examples, there's lovely trends towards the positive across all of these areas. And I'll stop sharing there. Thank you.
That's great. Thanks very much, Yvonne. And Yvonne will rejoin us later for the panel discussion. If you have any questions for her or any of the guests, please do send them to us using the chat function. We're now joined by Yvonne's colleague, as she mentioned. This is Jane Brownlee, and Jane is clinical specialist, occupational therapist, and set up the pilot in the Kildare West Wicklow She's going to tell us about the process of the pilot setup and the awareness raising work around the service and the story really of the last 8 months. We'll also hear from some of her patients and the reaction of a local GP to the service. Jane, you are very welcome.
Thanks for having me. I'll just share my slides. Okay, sorry. Okay, so thank you for having me. As I said, for the introduction, I'm delighted to be able to share some of my own experiences of setting up the service and delivering it in the Kildare, West Wicklow area. So my background experience is in rheumatology, and I have a special interest in vocational rehabilitation. So to be involved in this project from the early stages was very exciting for me personally. So there were a number of steps involved in setting it up in my area. I suppose initially it was about building relationships with my primary care colleagues. The primary care occupational therapy manager linked me in with the 5 network managers across the area who were very supportive of the project and offered physical space for me to operate my clinics from. So from early on, I was set up across 4 different primary care sites in Naas, Newbridge, Athy, Clane, and also operating from Naas General Hospital as well. So I run a weekly or fortnightly clinics from those areas, depending on the number of referrals from the area. And then building awareness of the project, I attended clinical team meetings across primary care, met with the OT, physio teams in primary care, and I suppose any opportunity I could to get the word out there. In relation to the GP engagement, then there's been a number of steps with this. Early setup of a health link, which is the referral system that GPs use, was a first point, just to ensure an ease of referral system to us. There are a couple of GP leads in some of the networks around Kildare, West Wicklow, so they were helpful in circulating the information. And then I took time really to visit in person a number of GP clinics and meet directly with GPs to inform them about the service, which took time, but actually this was probably the most beneficial in terms of the numbers of referrals increasing from those contacts. And then, of course, educating my own local rheumatology team for the hospital-based referrals as well. So once the referrals were coming in, and they started coming in from the get-go, I was able to then start providing the earlier intervention service. And as Yvonne mentioned, this is a very flexible service to meet the individual's needs. So this is something that's very enjoyable about the work, is that I can meet the individual's needs in terms of scheduling their appointments, the timing, location of where I meet them, whether they contact through face-to-face or virtual appointments. Usually people attend with a mix of those appointments, and then being able to offer worksite visits where clinically indicated. So I think the early intervention piece, as well as the flexibility, has been a strength in the service so far, and has helped support the treatment outcomes that we're seeing to date. So I have 2 case examples to talk through today, just to give you an insight into some of the typical assessments and interventions that we carry out, and some of the outcomes that we're seeing. The first example is somebody that was out of work on referral and required support in getting back to work. And then the second example is somebody that was in work but struggling with their work role. And these are the 2 types of referrals that we're getting. So introducing Aoife, first of all, a 41-year-old woman who was referred in August last year from the Tallaght University Rheumatology occupational therapist. Aoife had attended the fibromyalgia program in Tallaght, but needed more specialized support in terms of getting back to work. So she worked as a clinical midwife specialist in ultrasound in a public sector hospital. And she loved her work, but she had been out on sick leave from March of that year. So she was out of work nearly 5 months when she came to me first. She'd also trialed a short period of returning to work, but had gone out on sick leave before that. So she had lost a lot of confidence in her capacity to work, and she wasn't really sure about how to navigate the journey back to work. So when I met her first, she had a range of symptoms, having a significant impact on her participation across all her activities of daily living and her life roles, her leisure participation, her social. She was living with her parents at the time. She was out of work. And in her own words, she put it, she was existing, not living. So her main symptoms being musculoskeletal pain, headaches, dizziness. She had a lot of fatigue, sleep disturbance. She had been seen by the occupational health team in the hospital and had some informal liaison with her management team in terms of getting back, but there was no direct plan. And as I said, she wasn't sure of how to go about it. So we, as Yvonne mentioned, go through a number of outcome measures on our assessment to get a good in-depth understanding of the person. But just to pick out a couple, the future job expectation scale looks at the person's future expectation of their role. And she felt that it was likely that she would have to leave her job within the next 12 months because of her condition. The work role functioning questionnaire looks at a range of domains in the job. So for example, the physical demands, social, mental, and the scheduling demands, and so on. So she was scoring a 55% with a number of difficulties across all of those areas. She attended for 6 OT sessions, 4 face-to-face and 2 virtual via Attend Anywhere, the platform that we use. And this was between September and November of last year. She then came for her 3-month follow-up in February 2024. So within those sessions, we looked at a number of things, but the first focus was around hand therapy. She was having a lot of right wrist pain, holding the ultrasound probe in her work. So we looked at splinting and strengthening exercises. We broke down her work routine in terms of analysing what were the difficulties and problem solving ways around how to manage that. We did education around the legislation and her rights and entitlements as an employee with a musculoskeletal condition. I wrote a workability report for her, identifying the reasonable accommodations that we had collaboratively identified to support her phased return to work. Things like her setup in work, specific chair that she needed, wearing her splints, taking breaks, those sort of things. And alongside all of that, we were looking at how she could self-manage her condition across her other life roles, so managing her symptoms and getting back to her valued routines. And always signposting to resources and supports networks that she could avail of. So in this case, it was Arthritis Ireland, who she linked with. And then she started her phased return to work on the 14th of November. And so she got back to work at the end of our, when we discharged. And there's a lot of outcome measures here, but just highlighting, I suppose, some of the positive changes we saw all the way through to the 3-month mark. So in terms of her future job expectations, she felt at that point at 3 months that it was very unlikely that she would have to leave her job, which was a really positive change. Her work role functioning went up to 90%, so identifying much less difficulty across all of her job tasks. Her confidence to work, which is a really important one, went up to 9 compared to 6 initially. And her perception that her work would not make her condition worse improved as well. So she was 7 out of 10. Quality of life measure that we use went up, and that was sustained at 3 months. And then her arthritis impact questionnaire showed a reduction in score, which is a good thing. It's less impact of her condition, of her symptoms on her day-to-day routine. So we have an audio clip from Aoife herself, who was happy to share today. And I think we have that now.
Program. I initially just thought this program would be helpful in just supporting me to take those first steps in returning to work, but in reality this program has given me so much more. This service and Jane has been so amazing. Jane has been so caring and empathetic. She has not only provided me with the physical tools to make daily living and returning to work easier, but she has also provided me with strategies and techniques to help manage pacing, stress, pain, sleep and exercise, and also help problem solve issues I face daily with simple activities and in the workplace. Jane has also helped me to view things in a more positive way, aiding me in finding solutions, adjustments, so that I can still achieve values that are important to me. But above all, she's encouraged self-compassion and self-advocacy. I will be forever grateful to Jane and for having the opportunity to participate in this vital programme. It has been a lifeline and has helped and supported me in navigating my way to get my life back, and also to accept and adapt to my new normal. So thank you. I feel hopeful again for the future and a successful phased return to work.
So that was Aoife's experience. I'll just go back to the slides. Okay, so just moving on to the next person who I mentioned. So Audrey is a 48-year-old woman who was referred to the service in July last year from her consultant rheumatologist, and she was experiencing work difficulties. She was working as a chef manager in a canteen for a large private organisation, and her main symptoms were lateral epicondylitis, which is otherwise known as tennis elbow, carpal tunnel syndrome, and she had some widespread pain associated with her early arthritis. So on our assessment, her main symptoms were right elbow pain, tingling in her hands, reduced grip strength. This was understandably really affecting her ability to do her job. So difficulty peeling, chopping vegetables, lifting pots. She identified a lot of stress associated with the pressured work environment. There was short staffing, staff shortages, and she felt just a lack of support from her management. She had brought some of these issues to her management before, but didn't feel that things were being addressed. She had concerns about her health affecting her ability to work over the next few years. Her work role functioning questionnaire was 71, so not too bad, but the main difficulties were across the physical demands, and as well as that, the scheduling, kind of doing a lot of overtime and not taking breaks and that sort of thing. I suppose the biggest thing on our assessment was the number of days that she had had absent over the last 6 months due to her condition. She'd had 30 days off because of her condition of sick leave, and so she was really struggling to stay in work at that point. We had 5 OT sessions between the months of August and February, so this was a little more stretched out. We were waiting for engagement from her manager, and that's why we took that bit of extra time. She had 3 face-to-face appointments during that time and 2 virtual appointments, and we're due to do her 3-month follow-up in May this year. Again, we looked at hand therapy for Audrey to address both her tennis elbow and her carpal tunnel syndrome, splinting and exercises and so on. We again broke down the typical routine and patterns in her working day, looking at her methods and positioning, looking at how to integrate refresh exercises, micro breaks, that sort of thing. I wrote a workability report for Audrey as well, identifying some reasonable accommodations. She came up with the recommendation around a piece of equipment that she felt would really help her condition, the RoboCoop food prep machine, but it was a very expensive piece of machinery, and it hadn't been provided before. So she was provided with this, and this made a massive difference to the amount of food prep that she had to do on a daily basis. She was provided with a laptop for her kitchen admin work, and she was provided with an additional staff member. So that made a massive difference to the workload. So there's really good outcomes. She stayed in work, and she reported no concerns about her future job ability. Her work role functioning questionnaire went up to 91%. She had stated initially that her employer had refused the accommodations before being involved in the service, and then at discharge that they had provided the accommodations. Her confidence levels went up to 10 out of 10, and she felt that her quality of life as well went up to 85. Her arthritis impact questionnaire, again, she had less impact of her symptoms on her day-to-day routine. And I suppose the big outcome here was 0 days of sick leave in the last 6 months when we redid her measures, compared to 30 on our baseline assessment. So she was doing really well. She wrote a couple of words in terms of her experience. So I'll just read that a snippet out from that. So she said, "These changes have made a significant difference in my daily work routine. I'm now able to manage my pain and continue working without the fear of having to give up my job. It means a lot to me that there are schemes like this available." And finally, I have one more testimonial, an audio from Terry, who also attended the service, a 59-year-old woman who was referred with work difficulties, and she has inflammatory arthritis, and she works as a full-time receptionist in a leisure centre. So I think we can share that audio now.
Hi, my name is Terry, and I've been working with Jane in Workable Solutions for a few months now. I was asked to attend as I had trouble in work. My work-life balance was seriously compromised, and I'd been out of work for a few weeks due to my arthritis. I had initially hoped to claim partial capacity so I could cut my work hours, but that's not possible unless you are on illness for more than 6 months, and that's not something that I can do. Jane helped me physically by giving me a few aids for my arthritis, such as my special scissors. Thanks, Jane. She wrote a very detailed letter to my employer, which has helped considerably with my shift hours. The best help she gave was to acknowledge my struggles and help me to mentally adjust to my illness and find ways to work while suffering with my arthritis. Working with Jane and Workable Solutions has helped me to look at my work and illness in a better light, a clearer focus. It is invaluable, and I would access it again in the future if I needed to. Thanks, Jane.
So that was Terry's experience, and we now finally have, from a referrer's point of view, Dr. Kevin Kidney sent a letter from his experience of referring to the service, and that's going to be read by Gary, I believe.
Workable Solutions has quickly become an invaluable resource. As a primary care physician, I cannot emphasise enough the importance of timely, local access to occupational therapy for my patients. We are all aware that the longer the time out of work, the lower the chance of sustained return to work. One of the most striking aspects of the service is the quick access it offers. My patients have been seen promptly. In the case of people who are struggling in work, the short waiting time has avoided this need for sick leave at all. Having a local service means a wide, inclusive cohort of people have access. Knowing that my patients can access high quality occupational therapy right in our community brings a sense of reassurance. It eliminates the barriers of distance and inconvenience, allowing individuals to focus on their health and well-being without added stress. I've referred several patients to Workable Solutions, and the feedback I've received has been overwhelmingly positive. Workable Solutions is set apart by the high quality of care provided. The tailored approach to therapy considers not only the physical aspects, but also the unique demands of each person's life and work environment. My patients have expressed gratitude for the personalised care they've received and the tangible improvements they've experienced in their daily lives. One person has particularly benefited from the information provided on non-pharmacologic chronic pain management. Among the cases I've referred, there are notable examples of complex and challenging scenarios. For instance, a patient suffering from months of debilitating lumbar nerve impingement has been able to continue working while awaiting decompression. Similarly, an individual with epicondylitis has successfully returned to a demanding physical occupation thanks to the tailored therapy they received. I wholeheartedly recommend Workable Solutions occupational therapy to anyone seeking expert care that is both accessible and effective. The commitment to helping individuals stay engaged in their occupations is truly commendable, and I am grateful to have such a valuable resource in our community.
Thanks. So that's all from me.
Super. Thank you so much to Jane and to Yvonne, and indeed to Gary Killeen, who did the lovely voiceover of the GP there in that last audio piece. Really great to bring those testimonies to life by hearing the voices. So thanks to Jane and Yvonne for the detailed picture. And as I say, the testimonies talking to those who have engaged with Workable Solutions, speaking about it being invaluable and a lifeline for them. I want to invite both of you back now, but I'm also joined by Martina Blake. Martina is with Arthritis Ireland. And Martina, we've heard some of the testimony there of users of the service. You're very welcome. Can I come to you first, Martina? So what is the role of Arthritis Ireland, and how important is the work of this project, in your view, to people living with arthritis?
Thanks, Grania. Nice to be here today. I suppose Arthritis Ireland is a national charity in Ireland for people living with arthritis. And our role is to provide information, support, training, and education, and all things arthritis to people living with arthritis. And, you know, we're very grateful to be here today to provide an opportunity to let people know that we're here. I popped it into the Q&A already. Our helpline is a free helpline for people, and there's some questions coming in that maybe weren't answered today. So, you know, feel free to call the Arthritis Ireland helpline. It's 0818 252 846, and or pop onto our website www.arthritisireland.ie. And I suppose it's really about patient information that we provide in the form of patient information booklets on arthritis. We have a series of podcasts, Inflammation Nation, with a lot of different topics. We have videos on particular conditions and diseases and you know, specific topics around that. We have what I see the correlation between OT and what we do in Arthritis Ireland is we're all about self-management. Right. You know, in self-management, some people go, what is that? You know, it's about living your best quality of life in spite of your condition, and it's learning about pacing. It's learning to understand your condition. And I suppose we're slightly different because our programs are delivered by people living with arthritis. So it's peer-led, and, you know, it's about behavioral change. So it's getting, you know, I heard a few people mention suffering today. So it's getting out of that suffering mentality and into the can-do and into the positive. And our Living Well with Pain program is available online, as our Living Well with Arthritis programs are available in the community all over the country, and they're online as well. And they're a great starting point for anybody, you know, that's trying to learn more about how to take on the challenge of living with arthritis. And as I say, I see that what we offer with that really does dovetail with the Workable program.
Right.
And that's a real topic. Workable and being able to stay in work is about self-management as well. It's a real hot topic on our helpline. And, you know, a lot of people would call in, you know, and that's that devastating impact of, how am I going to work? I have a family, or I have a mortgage, or what am I going to do? What about the future? And our helpline is, you know, well able to, you know, point people into their benefits and entitlements, what their rights are, who to ask, how to ask, you know, how to go to Occ Health at work, you know, how to have those conversations with employers, you know, and you know, that's the stuff that keeps people awake at night. That's the stuff that, you know, causes the stress, so people aren't managing well. So as I say, I think the two complement each other.
Very much so. Yeah. And Martina, I mean, it sounds from what some of the testimonies are saying as well is, as you say, that balance of what can I do to manage it, but then working with the OTs around getting the kind of support. I mean, so I know it's early days, but some of those outcomes are pretty impressive. You know, people going back to work, no sick days in the last number of months. So obviously the combination of being able to, I love the Terry's thing about thanking you for the special scissors, you know, very practical supports that people are having that make a difference. Yvonne, can I come back to you for a moment? We're getting a number of questions in about interest in, is this going to be piloted? Will we see it around the country? Tracy, who is herself an OT working in primary care, was asking, are there plans to extend this into the west of Ireland? Also the northwest and the west. So your sense of, are there plans? People are definitely saying there's demand.
Yeah, I think that's so true, Grania. And this is a project that's still underway. We're continuing until the end of December this year. But what we're definitely demonstrating to date is that there's an appetite and there's a need for this type of service. And what the pilot is doing at the moment is really measuring the impact of the service Again, looking at the impact from that pathway point of view, that person point of view, and the societal impacts. We, in the current team, and I suppose just to acknowledge the current team does include Professor Kane and Gary Killeen and the National Clinical Programme, Jane Brownlee in Naas, Katie Mahan operating service in Waterford, and Susan Somerville in Vincent's, Tyke Stapleton in Trinity, and myself. We're continuing, I suppose, to work on evaluating the service so we can make evidence-based commentary on the impact, and we'll be using that information to again continue to advocate and to agitate so that this service can be included for consideration for further rollout. And my ultimate aim is that this should be business as usual nationally. I don't at all believe that this is an Eastern border issue, but we did pick the pilot sites at the time based on existing relationships that were there within OT services, and that the hospital services knew what OT could do in the workspace. That's why we picked these 3 sites. And then our education curve was around primary care. We've been doing a lot of work within our Rheumatology Musculoskeletal Disorders Advisory Group as part of AOTI, promoting occupational therapists nationally in terms of their skills and confidence in this area, so that they will be equipped to take on the baton if we can leverage the change that we're looking to leverage. So this didn't happen overnight. We started in 2018. We'll continue to work on this, but we're trying to prove the worth as well as deliver what I certainly believe is a very impactful and valuable service.
For sure, and we're seeing the start of those outcomes for the people who are involved in the pilots. Jane, if I can come back to you, I mean, earlier on, I think it was Yvonne who mentioned that, you know, this is one of the most, people with these conditions, it's one of the most common reasons for people attending GPs. So is the flexibility of what you're offering, is that, for me, that looks like one of the key innovations. Do you want to just comment on the importance of the flexibility? You even mentioned the possibility of having, you know, video link, face to face, that kind of flexibility.
Yeah, I think this is key for the just engagement and for people even attending, you know, because people, as Yvonne had said, about 79% of people are in work and struggling with work. So a lot of these people are working 9 to 5, Monday to Friday. So it's difficult for them to get away for appointments. So, you know, in my week, I have slots for 8 o'clock appointments, 4 p.m. appointments, and lunchtime virtual video calls, so that there is so that it makes it possible for people to attend. And I suppose the other piece is the integrated piece into primary care. So for people living in Athy, that they can just schedule their day to meet me when I'm there. So I think this really does make a big difference to the engagement, and thus, I suppose, influencing then the positive outcomes. Yeah,
for sure. And I have somebody sending in a message from Teresa. And Teresa says, I work as a senior physiotherapist in ergonomics in St. Vincent's University Hospital. There are 2 physios working in this area. Our role is to promote, protect and manage MSK health for employees. We run a fast track working back clinic in conjunction with the ANPOH, which has similar aims to this programme for 4,000 staff in the SVUH. This is very interesting to see such excellent outcomes from Workable. So that's a colleague, I think, paying a compliment and just talking about, you know, other maybe initiatives in this area. Just maybe to ask also, site visits were mentioned, Jane, just briefly, just whose site, what does that?
Yes,
you know?
so that's really the person's workplace, and I suppose I've done about 6 over the last 8 months. They're not common with everybody. A lot of people don't identify the need, as is sort of commonly expected sometimes when you talk about work engagement. But so the people that have opted in for a worksite visit, some of them are working from home, and I've done sort of ergonomic and functional assessments from their workplace at home. I did an interesting one a couple of weeks ago for a person that had been out of work for 6 months from his factory work. So we were problem solving around which factory department to go back to. So I went and did a site visit to the factory to look at, in this case, it was a pizza factory, and we looked at the topping department, the bakery, to work out really what was the best decision in terms of his return to work. So there's definitely a place for it when it's clinically indicated. And then a lot of people just want to get the advice from me, go back to their workplace and engage with their employer and self-advocate once they have that information. So
and I think that really speaks to the employer engagement, doesn't it? And we saw it as well in some of your case studies that really, excuse me, in the first instance, employers might be a bit reluctant or they don't understand. But actually, I think with your engagement, they begin to see, okay, so we can hold on to this person and there may be some tweaks we can make to enable this person return to work or not have any further sick days. Martina, can I call you back in for a moment? There is, I think, an interest online around the work of Arthritis Ireland. And, a specific question around, does Arthritis Ireland support those who have chronic and persistent pain conditions, but who don't actually have an arthritis diagnosis?
I suppose the short answer for that one is we deal with anybody with arthritis and related conditions.
Okay.
So depending on what it is, there are other charities that deal specifically with chronic pain. So say it was neuropathic pain or pain related to cancer or diabetes, that wouldn't really fall into where we are. But certainly if somebody's living with pain, I did answer that on the text that by all means check out the website. There's loads of information there on pain management techniques. There's a 6-part webinar on there, breaking the pain cycle, and it's everything from diet, exercise, mental health, pacing yourself,
right,
and inflammation. So if there's anything there that's any good, our YouTube channel has all of that there. And there's a generic non-specific program called Living Well, which is delivered by the HSE, and it's available all around the country. So if that was of any help to somebody, because really self-management is where we need to be going.
Exactly. I must say I'm surprised by the number of, and again, our audience here is mostly people from within the wider HSE family who are coming in with their own issues, their own conditions, that rather than even looking at clients. I mean, there's one here maybe for you, Yvonne. I'm currently seeing a rheumatologist for psoriatic arthritis, taking methotrexate. I'm on it 6 months, blah, 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 but I feel it's not doing anything. Would Workable Solutions benefit me more? So that's kind of a request about a review of what she's currently on. Would Workable work for this person?
Yeah, and I think that's really important. It's because it's highlighting the fact that oftentimes people are waiting for their medication management to get them to a stable position to then review their landscape.
Yeah.
The problem is that this is a very dynamic process whereby they're in work and struggling and their medication and trying to find a point of drug therapy that's working really well for them needs to happen concurrently. And I think that an in tandem approach, if that person was in the catchment areas for this pilot site, then it would be very appropriate for them to link either through their rheumatologist or through their GP so that they could access the service. An awful lot of work loss happens while people are trying to get their condition stable. And I suppose that's where we want to be flexible and be able to be available in an early way, that we can provide the right type of care that is required, that is work focused. So considering the fact that maybe condition is not as stable, but working with them in that moment to help keep people in work, because we know if we keep people in work and as things stabilize, their work retention rates will improve. But the longer somebody is out of work, like all of us, the more complex other feelings and emotions and anxieties kick in too, which can become barriers as well. So the in tandem piece is, I suppose, what's really important there.
Yeah, absolutely. And it speaks right back to the Sláintecare, right place, right time, as you say, which actually is a lovely way to round off our webinar this afternoon. I want to thank each of our guests here today and all of our panelists. Thank you to the team who helped to produce this session, Rosaline Harlan and Tom Duke. You can watch this webinar back or recommend it to your colleagues. It will be available on the Sláintecare website. So for me, Gráinne Healy, continue to stay safe. And until next time, Thank you and a very good afternoon.